morning and welcome to the 2013 College of Nursing Annual Keynote event. This annual gathering has proved to be a dynamic and inspiring forum for presenting ideas that are at and beyond the cutting edge in nursing and healthcare, with a scope that is worldwide and a vision that is unlimited. I am pleased you could be here tonight. We are about to hear an intriguing and inspiring keynote presentation from Seattle U College of Nursing graduate Rebecca Conte-Okello. Rebecca has taken to heart and put into action the Jesuit principle of seeking social justice through the use of her professional skills. She understood, as we all should, that the scope of practice encompasses the world. Crossing borders, cultural and international, is an integral part of today's nursing practice. It is easy to talk about social justice. It is challenging to be part of making it happen on a global scale. Doing so involves global engagement. It involves challenging our own beliefs and assumptions, being open to new ideas, and developing respect for what we learn as well as what we teach with each encounter. And striving for social justice involves taking risks. Risk as the cost of pursuing social justice, and it's ultimately a small price to pay for keeping our commitment to Jesuit principles. The willingness to boldly assume risk in pursuit of social justice is one of the distinguishing features of the Jesuit community. From its founding in the early 1500s, the Society of Jesus has focused on global engagement. Today, Jesuits can be found educating, ministering to their sick, and promoting social justice in 112 countries located on 6 continents. We, you and I, and this university are part of that commitment. Yet, just going to other places isn't global engagement. It's simply well-intentioned social tourism. Engagement is an act of mutuality and equality. Engagement is about partnership, not paternalism. And ultimately, engagement is about learning as well as teaching. Engagement, properly done, is an act of humility, an acknowledgement that others have as much to teach us as we have to teach them. Sickness or health and the cause of both are an intensely cultural calculation. If a cut on my finger becomes infected, I believe it is because of bacteria, and that antibiotics will be curative. Other people in other places may believe other things. Global engagement means striving to understand those beliefs, learn about them, and respect them as being real and valid within the context of that particular culture. That respect is the foundation of a partnership in which the partners are equal, the goals are shared, and the outcomes likely to be mutually beneficial. This kind of partnership is not created with armchair or classroom knowledge and skills. These are things we learn and teach by being in the world at large. If we are to continue and extend the Jesuit commitment to creating social justice everywhere, leveling disparities and differences that lead to lack of healthcare resources, and saving lives that should be lived rather than sacrificed, then we must cross borders. Global engagement is inescapable. Nursing is a global profession. We must move from principles of social justice to the practice of social justice, using all available personal and professional resources. That is the Jesuit commitment and our commitment as nurses living in a global world. In a world where the most distant points are only hours away by plane or milliseconds away by computer, mad boundaries have have less and less ability to divide us. But what is it that will unite us? Healthcare holds the promises. There is no country, no culture, and no religion that I know of which does not hope for good health. So we must all decide individually and collectively how real our commitment is to solving disparities and promoting social justice in the world. If you say, but what can I, just one person, really do, then I invite you to listen with your heart as well as your ears to our keynote speaker tonight. To provide the introduction of our keynote speaker, as well as a bit of insight into her path from the Seattle College of Nursing to Kenya, I would like to invite to the podium one of our faculty members, Dr. Anita Jablonski. Dr. Jablonski was the one who worked most directly with tonight's keynote speaker when she was an SU undergraduate, and who spent a substantial portion of her sabbatical leave in Kenya at Rebecca's clinic last year. So ladies and gentlemen, this is Dr. Anita Jablonski.
I always want to cry when I have to talk about Rebecca because she's kind of become the daughter that I never had. I have two sons, and just standing here right now, I feel like I could cry because she's been so successful in what she's doing. But I really am honored to be able to introduce her to you tonight. As the dean said, she is a 2007 graduate of the College of Nursing, and in 2009 she was the recipient of the Seattle University Outstanding New Alum Award. And like the dean said, I've had the opportunity to work with her not only as a student, but as a board member of Med 25 International. She is the founder and the executive director of Med 25, and the organization is really aimed at providing rural African communities with affordable, quality, and culturally appropriate health care. She established Med 25 in 2006, and she usually goes to Kenya 2 or 3 times a year to do programming and also to catch up on what's going on. Plus, she's in constant contact with them when she's here. She is, I love her so much. She's so tremendous. So currently her work is in Mamita, Kenya. It's located in the southern end of Lake Victoria, and it's a very rural community, very poor communities. But while she's here in this country, she does a lot of fundraising, which has been a challenge lately. She works with other nonprofits, and she also recruits volunteers like me. Fortunately, I've been able to see her work up close and personal. Like the dean said, I spent a month in Kenya last fall, and I've seen the vital services that Med 25 Clinic provides to the community. And from being there, I know that her clinic has a great reputation for quality care. Patients will come to her clinic rather than going to the government healthcare resources. And it's really proven by the increase in patients that she sees. Just from January to March, they saw over 4,000 patients, which is amazing. So, anyway, her work is continuing. I hope to visit again, and welcome, Rebecca.
Thank you all very much for coming tonight. Very sweet words from Anita. I think she gives me a little bit too much credit, but I'm so fortunate to have the community that I have and the people that are interested in investing in Med 25 and what we do. I always like to start with a quote, something that has meant something to me at some point in my journey or is significant now. And the quote I picked for today was, "Never doubt that a small group of thoughtful, committed people can change the world. Indeed, it's the only thing that ever has," by Margaret Mead. So to tell you a little bit more about myself, I was born and raised in the Seattle area, came to Seattle University, and it had everything that I was looking for in an education. It had the Jesuit morals and values, specifically focusing on social justice. and the importance of caring for others. And it had a stellar nursing program, which I had known from a very young age that I wanted to go into nursing. My mom is in healthcare administration and was a wonderful role model for that. And my dad is a professor in the School of Social Work at University of Washington. So I was instilled in the importance of caring for those less fortunate and for always giving back whatever I was privileged to have. I started volunteering when I was in high school. Would do mission trips to build houses in Tijuana, Mexico, and it was something that kind of sparked my interest in working internationally. I went on to volunteer in countries like the Dominican Republic to teach English to Haitian refugees, but I'd always felt a calling to Africa, and I didn't know what that meant or what it would look like, but I ventured out on my first trip in 2006 to the West African country of Ghana. And I fell in love instantly with the culture, with the people who had very little, but would do anything to make you more comfortable. They would be struggling to buy their own medications, and they would give you money, or they would give you food at their house every day. And that hospitality and generosity was something that I didn't know existed. I came from a very privileged community here in the U.S., and things that I viewed as basic standard rights, that everything that I would need were viewed as luxuries in Africa, and specifically in this community in Ghana. And I was there for 3 months and returned home and knew that I wanted to do more. I didn't know what that would look like. I was focused on being a senior college student and graduating from nursing school, which was a challenge at times. And I found myself connecting with a new network of people that wanted to help. They heard my story, they heard what I was interested in and how I wanted to make a difference, or thought I could make a difference. And through a chain of events I can't quite explain, I somehow founded my own nonprofit organization, Med25. And our mission is to provide quality, culturally appropriate, and affordable healthcare while focusing on one community at a time. Our name, Med25, comes from the Universal Declaration of Human Rights, Article 25, stating that all humans have the right to a certain standard of living, which includes access to food, health care, clothing, housing, and necessary social services. So as an organization, our goal is to provide those, the medical aspects specifically, and other social services, depending on the needs of the community. Our first project started in 2006 in Ghana, and we worked there from 2006 to the end of 2008. And our project was a partnership with the Ghanaian Ministry of Health and the Ghana AIDS Commission, and with a community-based organization there. And our work was really focused on an HIV/AIDS care center. They didn't have appropriate HIV care, and so what we did was we partnered with them and created this facility that had a clinic, nursery school, vocational school, and orphanage. And that HIV care center is still operational today. It's run by the community-based organization in collaboration with the Ghanaian government. Ghana was a very unique situation for us. The government had the financial means in order to support a facility, but they didn't have the physical structure, which is opposite from the other 9 African countries that I visited to assess projects in. They usually have infrastructure, but they're not able to pay for the ongoing operations of the facility. So there are some key lessons that we learned from our project in Ghana. First is that you can't isolate HIV. When patients would come to our facility, they were almost outed as HIV positive because it was known as an HIV positive facility. Also, you're providing holistic health care to HIV positive patients, and if you're excluding those that are not HIV positive, you're missing a key time to provide education and prevention of HIV. So that was one of our big lessons. Another thing that we learned was the importance of self-sustainability, is that we needed some sort of income generator or some sort of guarantee that we wouldn't be relying on foreign aid forever. It was something, in Ghana we were very fortunate to have a partnership with the Ghanaian Ministry of Health, but we knew we needed something else in future projects. So in 2009, I took 6 months leave from my job at Virginia Mason, where I still work today full-time as a nurse. And from that experience, I traveled around and was invited into different communities to get to know what their health concerns were and how we could make a difference if we were to partner with these organizations. There were a number of things that we saw with the healthcare clinics that we evaluated. One was they tried to make it a self-sustaining entity in itself. So they would charge patients enough to cover the cost to operate the clinic. Unfortunately, sometimes you're losing the poorest patients is the population that you're trying to serve. So that was an unsuccessful model in some of the communities that we saw. They were seeing maybe 10 patients a day when they had the capacity to see over 100 patients. And it was simply because the services were too expensive. Next, sometimes healthcare clinics will pay unfair wages to the staff members that they're employing, or they use unqualified staff members to run facilities. They will have nurses running entire hospitals without any sort of physician's assistant or nurse practitioner. And while that's putting a lot of trust in the nurse, it's also oftentimes asking the nurse to operate outside of their license within the country that they operate in, which is an unsafe situation for a lot of the patients. And then lastly, clinics that we saw, they relied on outside or foreign aid forever. They didn't have any sort of solution for long term. So there was a clinic in Umvita, which I'll talk about in a minute, before we were invited, that was operational for 15 years. And the person who started it was a doctor from Holland, and she passed away and then didn't have, her friends kept it up for another year or so, but then they lost interest in the project because it was really her project. And that was something that it was very unfortunate for this community to then lose the health care that they had relied on for all previous years. How Med 25 is different is that we believe in kind of a number of different principles. One is we believe that you should focus on one community at a time. So we don't want to go around and build 40 different hospitals and have kind of the number of accomplishments after our name. It's really important to us to make sure we're doing it right in one community. We are a small nonprofit organization. We make sure that we don't bite off more than we can chew, and we want to make sure that we're successful in that community so that it's something that 15, 20 years from now we know is still operational. Next, we have a focus on a community health approach. So it's not just about what we do within the clinic walls, but it's about getting out into the community and providing outreach, care, and support in remote villages that need it most. Also, our facility must always be run by locals, and it must have fair wages for all staff members. So we don't want to be known as a white person clinic that is always staffed by volunteers. So if we don't have a volunteer, we can't open our doors. We want to make sure that we're always able to provide the care that we need through local staff that can provide culturally appropriate care. They can know what local herbs and other things that patients will be taking that I myself will not know about. We also focus on the importance of implementing income-generating businesses. So we have to have something that we can create that's a part of the project that can generate income. In the Ghanaian project, we had the Ghanaian Ministry of Health, which was very helpful in running the clinic, and then we also had the vocational school that helped generate income towards sustaining the orphanage, which is another part of the project. And then lastly, it's all about strength in numbers. So we believe that partnerships are the key to success in working abroad. And it's not about trying to be the one that gets the acknowledgement or that is trying to do everything at once, but it's about partnering with other organizations that are doing successful things already in that community and working alongside each other to truly elevate a community. So in 2009, I came to Kenya and was invited by the community of Umvita to go and visit them. Umvita is located along Lake Victoria in western Kenya, and it's about 3 hours outside of Kisumu, which is the third largest city in Kenya. It has a life expectancy of 37 years of age and an HIV infection rate of 30%, which is compared to the national average of Kenya of 6.7%. So a very high HIV infection rate. It also, 48% of children are not immunized against preventable diseases, and 89% of women and 80% of men do not graduate from high school, so a low education rate as well. Umvita is home to over 118,000 people. It is, like I said, located right along the lake. A lot of people use Lake Victoria as their main source of water, which they also use to clean, they use to bathe, they fish out of, and use for their drinking water. There also are the fishermen along the lakes, and then farming communities up in the hills that comprise kind of this community. So in 2009, we opened the Med25 clinic, and the clinic, primarily what we treat right now is HIV, malaria, waterborne illnesses, dehydration, and respiratory infections. We also have a very large immunization program and antenatal care program. And then a key to our success is the community outreach, so our community health workers that work out in the community. We have 27 full-time staff members right now, all Kenyans. 12 work in the clinic, 15 work in the clinic and provide our regular care. We have 2 clinical officers, which are the same as physician's assistants, nurses, social work, pharmacy technician, lab technician, VCT, which is voluntary counseling and testing for HIV. And then we have our 12 community health workers, and those are primarily women who are out in the community, and they're our eyes and ears. They provide outreach education, they inform people about Immunizations Day coming up, they inform people if there's a cholera outbreak or something else in their community that they should be aware of. And we right now have 2 full-time volunteers. So a board member of ours and her husband believed in what we were doing, and so they moved to Kenya and are operating full-time as our country director and our construction manager for the One Community Project, which we'll talk about in a minute. We've also employed over 300 craftsmen or day laborers in the One Community Project, which started last June. In 2012, we treated over 12,000 patients within the clinic walls. We immunized an additional 2,940 children against preventable illnesses, and we enrolled 200 patients in HIV treatment, so people who are HIV positive and previously did not have access to antiretroviral drugs. Our average so far in 2013 has significantly increased, and we're treating about 1,600 to 1,700 patients every month since the beginning of 2013. The One Community Project was something that we started because we knew we needed kind of a long-term solution. When we first went to this community, we began operating out of a rented facility, so a building that was already existed in the community, but we needed a long-term plan of what we were going to do. So we slowly opened our doors, began seeing more patients. At the beginning of April, we celebrated our 3-year anniversary of being in this community. And we wanted to find out kind of long-term how we could create this community initiative that was centered around health, but was something that was self-sustaining within the community. And so we, from the beginning, since we were asked to create this clinic, we were asked to provide another service which was not present in our community, a mortuary. Now, when you talk to a Western audience about making income generation off of mortuary services, your donors sometimes step back a bit. And the reason, when you really think about it, is the closest mortuary is a few hours away either direction. It provides a very low quality care, and it's something that is a critical aspect of the Kenyan tradition of burying their loved ones. So right now what they do without those mortuary services is they bury bodies right after someone's passed away, which is this cultural taboo, or they have to pay hundreds of dollars, US dollars, to transfer someone to the closest mortuary to get this service, when they make an average of 62 cents a day. Or they leave bodies in the house, which causes all sorts of health issues for those that are still living. And so to truly be our culturally appropriate and make sure that we're listening to the community, that it's about their ideas and not ours, we investigated how we could open a mortuary. And so we've been working closely with a mortician here in the Seattle area who runs his own business, who's gone to Kenya to evaluate 15 different mortuaries in the area and see how we could stay true to our mission of providing quality, culturally appropriate, and an affordable service, while still making an income generator off of it so that it could support the clinic long term. The One Community Project was officially started in June. It also, besides the mortuary, will include a future clinic that is a much larger clinic than the one we operate out of right now. The one we operate out of is designed more to see a maximum of about 700 patients a month, and we're seeing double that. So having something that's better set up for caring for the patients in this community, and also something that's on Med25 owned property. And then lastly is volunteer housing. So right now we have a small volunteer program, but that's something that can also be an income generator for the project in the long term. The project not only will bring those buildings, but it's also brought things like clean water to the community. We drilled a well in the community that's the largest capacity well in the region. It will not only support everything we need to for the project, but it'll also we'll be able to sell it for a very small fee to the community in order to maintain a community separate pump. So they have access to that. And then it's also brought electricity. They've never had access to grid power in this community before, and we installed a transformer and gave us access to power while also giving other people in the community access to power. So in kind of our next steps as an organization is we'll be opening the mortuary in June of this year, so just a little over a month away. We'll continue to expand our healthcare services and make sure that we're providing the quality, culturally appropriate and affordable care in everything that we're doing. We'll be completing phase 2 and phase 3, which is the clinic and the volunteer housing. And then also invest in other businesses. So see how we can take the other things that we've learned, things that maybe don't require as much capital as a mortuary. It was a large building that required a lot of expertise, but we can do smaller things. For example, we are also investing in funeral services. So not only will the person be bringing their loved one for us to care for them and prepare them for burial, but they can also rent chairs and tents and other things that are needed as a part of a funeral service in this rural community in Kenya. And then there's also other small-scale business that we can do. There's a thing that how you pay people is through something that an application on your cell phone, and that's something that we're investing in as well. So a number of different ways that we can find a way to generate more income that can support the longevity of the clinic, to make sure that one day we can say, okay, this facility is self-sustaining, so now we can be less involved in it and move on to another community in need. Thank you.
Thank you, Rebecca. I'm so proud of sitting there and hearing the story that Rebecca shared with us, and this is the best way of showing how Seattle University College of Nursing Education can really create leaders for a just and human world. So thank you very much for sharing your story with us that we will all be a part of, and thank you for your devotion to the commitment of the Jesuit education. The concept of nursing being a global involvement and of our Jesuit educational heritage, encouraging participation in pursuit of social justice everywhere, merits a closer look and a more extended discussion. To provide the look and the discussion, we have invited a distinguished panel of experts who have been convened by our Global Nursing Committee at our college. And it is my pleasure to introduce you to Dr. David Citrin, the University of Washington medical anthropologist. Please stand up and come to the podium. Dr. Paul Christiansen, Dean of Northwestern University College of Nursing. Dr. Alpha Kone, Director of Côte d'Ivoire projects at Health Alliance International. And Suzanne Stolz, Vice President of Global Outreach at the American College of Nurse Midwives. It is largely due to the effort of the Global Nursing Committee at Seattle U College of Nursing, who has taken the leadership position in advocating for not only local, regional, and national involvement, but also through global engagement of nursing students and graduates. And that we have this wonderful panel here tonight to be able to discuss the issue of global engagement order. So Rebecca's work exemplifies the focus of the nursing, Global Nursing Committee. And the committee's 7 members are represented tonight by Ms. Jennifer Frikas, the chair of the committee, and Dr. Karen Cogill. And they will serve as tonight's panel moderator, and I now place the discussion in your very capable hands. Thank you very much and enjoy your evening.
Has a broad background in healthcare administration and holds a doctorate in public administration from George Washington University and a master's degree in nursing from the Oregon Health Sciences University. He was a Fulbright Scholar in Oslo, Norway, and an alumnus of the very prestigious Robert Wood Johnson Executive Nurse Fellow Program. So we're very pleased to have Dr. Christensen with us tonight. And Akapone, in addition to being the director of the Health Alliance International Programs in Cote d'Ivoire, is a native of that country. She's also a clinical assistant professor in the Department of Global Health at the University of Washington and an alumna of the University of Washington, where she got her master's in public health, as well as of Seattle University, where she got her law degree about 10 years ago now, is that right? And just this past February, she was honored by the law school with a Vanguard Award for distinguished leadership. So we're very pleased to have her here with us tonight as well. And David Citron has been conducting research in Nepal since 2001 on the ethics and politics of development and humanitarian intervention. And he recently completed his doctorate in medical anthropology and also holds a master in public health from the Department of Global Health at the University of Washington, where he currently works as a lecturer in the Department of Medical Anthropology. So very pleased to have David with us as well. And finally, Ms. Suzanne Stalls is, as Dina Mame said, currently Vice President of the Department of Global Outreach at the American College of Nurse Midwives. She has provided technical assistance to community-based organizations and economic development programs targeting capacity building of health providers and systems. She has been inducted as a fellow into the American College of Nurse Midwives and also served as chair of the International Health Committee of the